Hey guys, welcome. I'm Gary Gratz. I'm with CEF Paramedic Review, and we have some practice questions. So we've put five different recordings together, 10 questions each, and it's just some questions to help you guys just go over some questions with some explanation at the end of them. So let's get started. First question: how much fluid can you give a newborn? Well, the first thing that we got to talk about is what is a newborn, right? A newborn, by definition, is going to be any child in the first 24 hours of life. So the reason that's important, it's important to differentiate because 99% of the time, if you get asked like for a fluid formula, like how much fluid can I actually give a person? And honestly, for everybody across the board, a safe answer is 20 mLs per kilogram unless you're a newborn, okay? So be careful, because if you're a day old or 2 days old or 3 days old, you're not a newborn anymore. So your answer at that point is going to be 20 mLs per kilogram. But if you're a newborn, it's 10 mLs per kilogram for the first day. Okay. Now, obviously, there's some caveats to that. You got to be careful. If there's any cardiomyopathies, right, you're not going to go 20. You might want to cut it down to 10. Or possibly any liver failure, right? They're not making albumin anymore, so they don't have control of where the fluid goes, or you could get into renal failure or something like that, right? So you want to be more cautious with the amount of fluid that you give. But if you're just straight up asked with no caveats to it, most of the time it's going to be 20 mLs per kilogram. But for a newborn, it's going to be 10. All right, next question. Which organ is at highest risk for hemorrhage due to sickle cell anemia? Well, with sickle cell anemia, we know that the red blood cells are in that malformed shape, into that sickle type shape, right? And as those pointy edges start passing through vessels, it can start to cause damage, right? But which organ is more susceptible to that damage? And there's some juicy answers here. The kidneys, yep, there's a lot of microvasculature in there, absolutely can cause renal damage, nephron damage, right? The liver is a pretty juicy answer because a lot of times the liver is associated with red blood cells because of what the liver does, right? The liver takes broken down red blood cells and then conjugates that into bile, right? It takes that broke down red blood cells, and which is essentially bilirubin, right? And then the liver will take that bilirubin, oxidize it or conjugate it, and it turns it into almost like a substance that is able to be metabolized and excreted, right? Some of it will be turned into bile, and then some of it will actually be excreted in the stool, which is what gives your stool that brown color. If somebody has liver failure, they get to what we call a colic stool, right? Because they have liver failure, they're not able to conjugate those dead red blood cells anymore. So they end up with this gray, clayish looking type stool. But liver is not our answer either. Our answer is actually going to be, come on, little star, there we go, spleen. So the spleen is what you call it, a dual chambered organ, and the upper chamber is actually has more to do with white blood cells, has more to do with immunity, whereas that bottom chamber has to do with red blood cells. And believe it or not, the spleen is almost like a blood filter. As those red blood cells, if the red blood cells are healthy, they get to wiggle through. It's almost like a catch screen, and the little red blood cells get to wiggle their way through it, because red blood cells, they got, get my hand up here, they got like that convex that convex shape to it. But when the red blood cells get to that point where they die, they're not nucleated cells. So once they get to the point where they die, think of them as like becoming almost rigid or crispy, and then the spleen breaks them up. But the point is that the spleen also holds, I believe, 250 to 500 mLs of blood in case of hypovolemia, which makes the spleen more susceptible to hemorrhage from sickle cell. All right, third question. The sodium-potassium pump moves how much and in what direction? This is pretty important. I've seen this question pop up in several different ways, but this is a pretty common one. So the sodium-potassium pump is pretty important to know. And the reason is it's not just a fun fact. The potassium and sodium, that's your two major inter and extracellular ions, which is something else you should know. If you're towards the end of your paramedic program, you should know this, that sodium is the major extracellular ion, which means it's the most abundant ion outside of a cell, which is somewhere around 140 milligrams per deciliter. You should know that. And the other guy is potassium. That's the major intercellular. 99% of all your potassium resides intercellularly, okay? This is why anytime there's like a muscle contraction, right, depolarization happens. And it doesn't even matter what kind of muscle. It could be anything. It could be skeletal muscle, cardiac muscle. It doesn't matter. Anytime you have a cellular action, an action potential has to happen. And most of the time, you have what they call funny channels, right? And or a current. I think it's almost like a current where you go from a negative 90 and you slowly become more positive due to this this ion channel, this ion current. And then all of a sudden when it hits negative 70, that's your electrical threshold. And then sodium rushes in and causes a depolarization, okay? And it forces a bunch of potassium out. It does. But also, once you get to positive 30, a lot of those channels close, and then you go into a repolarization state, okay? And this is where potassium comes in and starts to repolarize the cell. Well, to fully get, in fact, what ends up happening is you go into a hyperpolarized state, almost so you can go through your refractory period and get reset. But once you've done that, the cell requires activity to be able to move ions back to where they belong, so the process can repeat. And that these channels or these pumps, these exchangers, they use ATP, so they use energy to be able to move sodium out and potassium back in. So here, let me click on the answer here. So very important is it moves 3 sodium out of the cell, and so it can make room and get 2 potassium back in. Okay, sodium is far more abundant. That's important to know. Sodium is far more abundant than potassium. We used to have this saying that if you had like hyperkalemia or you had too much serum potassium, we had an old saying that was, 3. If your potassium's higher than 7, you're going to heaven. And it just helped me remember that. And so your sodium levels, think about it, it's small. It's like only 3 to 5 milligrams per deciliter, whereas sodium is 130 to 140. So it's a lot. It's a big difference. Okay. All right. Next one. Oh, here we go. Little scenario. A 26-year-old female does not respond to verbal stimuli. A friend states the patient has ingested approximately 150 milligrams of amitriptyline. Vital signs are blood pressure of 90/54, pulse is 130. You establish an IV and administer fluids, good. And En route to the hospital, her ECG shows a widening QRS complex. What should you administer? All right. So, first thing right out of the gate, you read these and they throw a drug at you and 150 milligrams of amitriptyline. Well, if you know what amitriptyline is, you're in good shape. Okay, because that probably means that your school prepared you to treat TCAs. Okay? But what if you don't know? What if you sit for your exam and they hit you with a drug and you don't know what it is? First thing I'm going to do is I'm going to read through the question again, and I'm going to look for clues, because usually if they're throwing a drug at you, and a lot of times they throw drugs at you and they assume that you're not going to know what it is, but they'll give you a hint so you can work your way through it, right? It's all about priority searching. It's like, why would you ask me this question? What do you think I should know, right? So you read through it and you go, okay, 150 milligrams of amitriptyline, hypotensive and tachycardic, right? 90/54, you're like, ah, that's not bad. But with a heart rate of 130, okay, that's not good at all. So giving the fluids, you're already giving fluids, that's key, remember that. And en route to the hospital, and so here's your other caveat is ECG shows a widening QRS complex. Anytime I see widening QRS complex, I'm thinking one of two things. And honestly, because it's not just widening QRS, you have if you're widening QRS, you have a prolonging QT with it. And there's only two classes of drugs that you should know that prolong QTs or widen QRSs. And that's cardiac drugs or psychiatric meds. Okay, so what should you administer? If you just look at it that way and you go, okay, well, let's guess and say it's a cardiac med, right? And you go, okay, well, if they gave a cardiac med, what should I give as an antidote for a cardiac med? Well, there's only two cardiac meds that you give an antidote to. If they gave a calcium channel blocker, you could give calcium. Ooh, and calcium's an answer. Ugh. Okay. But if I gave a calcium channel blocker, calcium channel blockers, it's either, cardizem, which everybody knows, or there's verapamil, right? Cardizem would be also diltiazem, right? Or there's verapamil. But the other calcium channel blockers always end in pine, P-I-N-E, like amlodipine. What's the other common one? Amlodipine, nicardipine, something like that. That's not this. That's not this. Besides the fact, if you gave too much calcium channel blocker, you wouldn't be tachycardic. You'd be bradycardic and hypotensive. The other one could be a beta blocker, but beta blocker suffixes end in LOL. That ain't this. So honestly, just by reading it, I would lean more towards some type of antipsychotic, which is true. And honestly, if you wanted to guess, like if you were like, well, what suffixes should I remember to help me remember if it's a antipsychotic? Well, so the more popular one that you come across is tricyclic antidepressants, TCAs, and that's what this is. This is a TCA. Amitriptyline is a tricyclic. And I always, when I first started to try and remember these things, I always used to say to myself, okay, well, if it's a tricyclic, the two suffixes is M-I-N-E and L-I-N-E. And it's like, okay, well, crazy people walk the line until they step on a mine. Okay, I can work with that. But there's not just TCAs out there. There's a lot of drugs out there, like SSRIs, serotonin reuptake inhibitors. Holy smokes, there's a lot of those. And their suffixes are all over the place. But I will tell you that there is a plus side to this, honestly, is that you can look at suffixes and remember your calcium channel blockers, remember your beta blockers, right? Um, and then the rest of them, honestly, like, and of course there's your ACE inhibitors, right? Those are prils, like enalapril or something like that. But honestly, the rest of them, like, it doesn't, if you have MINE, LINE or something like that, or they hint at you at all that there's like depression or any hint of anti-anxiety, there's two things that you should worry about. Most of them, when you OD on them, they're going to cause tachycardia and hypotension. But the other big one, especially with TCAs, and that's why they love TCAs, is acidosis. Antipsychotics cause acidosis, and it doesn't matter which one you take. That's the plus side to this. Yes, obviously, some are definitely worse than others. Like tricyclic antidepressants have a very narrow therapeutic index, but it doesn't matter. If they give you a drug and you're like, I think that's an antipsychotic, okay, what are you going to do? I could give, there's no antidote, so I could give fluids. They're already doing that. I should worry about, airway. Of course, that always comes first. Well, there's nothing here there's not even an answer. They're looking for a drug. So honestly, yeah, I'm already giving fluids. What's my next thing? For acidosis is going to be sodium bicarbonate, right? Now, if they were to give you a question and be like, hey, watch out, they're getting a prolonged QT, what might you consider? Well, if I get a prolonged QT, that can lead to R on T phenomenons, which is torsades, okay? What do they love to give for torsades is MAG. So also watch out for that. They could push you in that direction as well. Okay. So, but for this one, they're really hinting at TCAs, acidosis. Metabolic acidosis is treated with bicarb. All right. What does this capnography waveform indicate? Well, first of all, capnography, right? This is a capnography waveform. Capnography waveform, if you remember, the normal is between 35 and 45, which is important. Okay. Remember your first portion where it's at 0 is your baseline, and then as it goes up, that's going to be your expiratory upslope. Remember, this thing only reads CO2, right? That's expiratory upslope. Okay. And then the plateau, that's points C to D. Remember, D is your highest point. That's the second. That's that back end of the cliff, right? And then when it drops off, that's your inspiratory downslope, okay? But if you look at this guy, you see the little divots in the plateau, the expiratory plateau. Those are called Curie clefts. So if you think about it, if you look at them, and you go, well, any upslope indicates exhalation. Yep, that's true. Well, any downslope, they're either holding their breath or they're taking a breath in. Okay, so if they're showing you Curie clefts, what they're getting at is this person is already intubated, they're sedated. I don't care if you had to use a paralytic or not, doesn't matter. They're sedated, they're intubated, and they're starting to come back. When you start to see Curie clefts, which is those little dips in the plateau, that's an indication that their inspiratory, their respiratory system is trying to turn back on. Okay, what are you going to do about it? Well, give them more sedation. Simple as that. So that would be, come on, little star. There we go. A is going to be your guy. All right, next question. So, what location is, V4R? V4R. Well, that's pretty simple because if you look at how all your normal ECG electrodes are placed, the only two besides, obviously lead 1 and lead 2, The rest of them are laid out in the fourth and fifth intercostal space. That's simple. So where is 4 going to go? Well, if 4 goes into the fifth intercostal space on the left side, B4R is a mirrored location on the other side, right? You move the fourth electrode over to the right side into the fifth intercostal space, mid-clavicular, right? Center of the clavicle on the other side, to look for right ventricular involvement. You want to look higher up on the right coronary artery to see if the right ventricle is involved. Because if it is, that means that that patient could be preload dependent. Okay, so that means that that patient is sensitive to fluid volume. So if you have a positive V4R, guys, no nitroglycerin in the realm of ACS. All right, so next question, guys. You respond to a 5-year-old complaining of pruritus and urticaria. Well, that sounds like an allergic reaction. So we have the patient also has a slight wheeze on auscultation. Okay, what is the primary treatment for this? Well, so you got to be careful of that. You got to be careful of the stem here. And what I mean is that the stem is the last sentence of the question. So what is the primary treatment? What is the next treatment? What's the first treatment? So these are things you got to be careful of. So here you have a 5-year-old that has itchy, hives, and they have a slight wheeze. It's 2 or more body systems. And what is the primary treatment? Okay, well, Benadryl is a pretty juicy answer. You could go, this is a screaming allergic reaction. I need an antihistamine. Okay. Albuterol and a steroid, also awesome answers. And these are all things that you are probably going to give. But does that make it the primary treatment? Should Benadryl be the primary treatment, or treating, the wheezing? Should that be your primary go-to? And the truth is your primary is going to be epinephrine. And the reason I say this is because, and I know a lot of times our books, they say, well, when you're gauging allergic reactions, it's mild, moderate, or severe. And I'm just not a fan of looking at it that way, especially because of questions like this. Because when they write some of these questions, man, they put it right on the line to see what you're thinking, see what your priorities are. And I'm a big proponent of, when you're reading allergic reaction questions, all you have to ask yourself is there 2 or more body systems? And if the answer to that is yes, then you're going to call this anaphylaxis. I think you should gauge these as allergic reaction, anaphylaxis, anaphylactic shock. Okay, there's your mild, moderate, and severe. So if you only had 1 body system, like if the 5-year-old only had hives and itchiness, okay, well, that's just skin. That's 1 body system. Benadryl all day, no problem. If you added a respiratory component to it, of course, we're going to go with Benadryl, and we're going to treat respiratory, right? Not in that order, by the way. You're going to do the Duoneb. You're going to give the steroid. You're going to do the Benadryl. Of course you are. But at what point do we lead with epi? When does epi become the first drug that we're going to give? And it's in the realm of anaphylaxis. And if you have 2 or more body systems, if you can say yes, and here we do, I have 2 things. I have skin and the respiratory system. That's anaphylaxis. Start with epi no matter what. Done. No matter what, that becomes the first drug you give. Okay? So how many body systems are there? There's 4, and you should know them. Skin, respiratory, GI. Everybody forgets about GI. So if they throw nausea, vomiting in there, or even just nausea, that's a body system. And yes, you can have an allergic reaction in your gut. Yes, you can. And then the last one's cardiovascular. Now that one, cardiovascular is kind of an odd one, because that if they throw cardiac in there, it's usually anaphylactic shock. You're usually going into a distributive shock question. So that you're going to go a different road for that. But still, at the end of the day, when if they give you anaphylactic shock, even though it's a distributive shock, epi is still your go-to, because epi still undoes histamines. It has the beta 1 factor, so the other pressors don't. So even in this type of shock, epi is still your go-to. You just might end up setting up a drip. But yeah. All right, next question. All right, so your patient has been complaining of chest discomfort. Patient denies any shortness of breath and is alert and oriented. This is the rhythm on your monitor. Blood pressure is 136/82, SpO2 is 98. What is your primary treatment? Primary treatment. All right, so what's the rhythm? Well, I got a narrow complex and it's very fast. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, doesn't matter. So it's a narrow complex over 150. That puts this in the realm of SVT. Simple as that. You have some Cannon waves over there. You see how your T waves become pointed? That is what you call Cannon waves. That could actually be, just as a fun fact, A waves or Cannon waves can actually be a sign of AV dissociation. That's where you actually start to get into trouble with SVT. But that doesn't matter. It doesn't matter. They gave you a cardiac rhythm. It's SVT. That's no question. And then anytime they give you a cardiac rhythm, honestly, your next question should be, are they stable or unstable? Without a doubt. Your patient has been complaining of chest discomfort. Be careful of that one. They deny any shortness of breath. They're alert and oriented, so A and O, good. Are their vitals stable? Yes. Is this a stable patient? Yes, this is a stable patient. They've been complaining of chest discomfort. Now, I know there's a lot of people out there that will tell you, whoa, they have chest discomfort or a chest pain that makes them unstable. No, it doesn't. No, it does not. If you look at the list of unstable criteria, and I know chest pain associated with cardiac origin is in there. Yes, that's true. But that's if they're having a heart attack. Okay? Does a heart attack make you unstable? Yes. Yes, it does. Does acute shortness of breath from bronchial spasms make you unstable? Yes. Yes, it does. Okay? Just because you have a sign or symptom does not make you unstable. It's what it's from. Okay? And in this case, no, just having chest discomfort with totally stable vital signs. If you think about it like this, right? You have a dysrhythmia. If a dysrhythmia were to make you unstable, how would it make you unstable? Well, the truth is if a dysrhythmia made you unstable, that means that the dysrhythmia gave you a low cardiac output. And to have a low cardiac output, the two things that you need to look for, number one is hypotension. That's first and foremost, low cardiac output that leads to hypotension. Number two is altered mental status. Are you altered from it? Because that means that there's not enough blood going to your brain. That's it, okay? Now, if other things can go with it, shortness of breath from hypotension, hypoperfusion, 100%, yeah, no problem. That's unstable. But you don't have any of that here. They have painted a stable picture. What's the primary treatment for SVT? All day long, guys. It's not shocking them. All right? It's adenosine, 6 milligrams of adenosine, without a doubt. All right, so you were called to a nursing home on a hot summer day for an unconscious 88-year-old male. The nurse tells you he missed his dialysis appointment. Okay, right out of the gate without reading another word, what is the first thing that comes to your mind? He missed dialysis. You may tell you when they read these questions, it's always about priority searching. So number one is anytime I come across a missed dialysis appointment, the first two things that enter my brain is number one is fluid overload and number two is hyperkalemia. That's always the thing that they're getting. Now, if he had just been dialyzed or he's new to dialysis, okay, that's when you get into other symptoms, right? That's like disequilibrium syndrome and things like that, or PE, or something like that. Missed dialysis, okay, well, he can't pee, so he's going to develop fluid, and now he missed appointments that got rid of fluid, okay? Think acidosis, hyperkalemia, and he has too much fluid. It's simple as that. So let's keep going. Oh, and he's got a fever. He missed his dialysis appointment because he was complaining of nausea, vomiting, and fever, okay? So he possibly has an infection, right? Which differential diagnosis should you consider first? Let's see what we got. A, hypotension. No, I don't even need to read anymore. He missed dialysis. He's not going to be hypotensive. That's ridiculous. Sepsis and hyperkalemia. Okay, there you go. Heart attack and low potassium. No, it's ridiculous. Anemia. I mean, he might have anemia, but not in this question. Or heat stroke. I mean, heat stroke, okay, it's a hot summer day, yeah, but still, B is a significantly better answer here, without a doubt. All right, guys, that's all the questions. I hope you enjoyed it. I'm going to put a bunch of these out. I'm also going to put on some mini lectures as soon as I get started here. So I hope that helped, guys, and thanks for watching.